there's a microphone up top. You're up top. See it right there on the left.
And then that's mute.
All right. Welcome.
Oh,
Welcome.
okay.
Can I get a thumbs up if you can hear me okay?
If you can hear me okay.
All right.
Um,
All right.
Welcome.
Welcome.
Sorry, there's a delay. Give me one moment.
Sorry, there's a
I'm gonna
delay.
use that
Give me
one
one
thing.
moment. I'm going to use that one thing.
Can I get a thumbs up if
Can
you
I
can
get
hear
a
me?
thumbs up if you can hear me?
All right.
I can hear you, but there's an echo.
Sorry, there's a delay. Give me one moment.
Sorry, there's a delay. Give me one moment.
Boy, that was confusing, huh?
Boy, that was confusing, huh?
There's still an echo. There's still an echo.
There is.
There is.
You can't have two devices close to each other that are on Zoom.
Are any of you guys close to
Are
each other?
any of you guys close to each other?
No, it would be you two.
He's not on. I'm gonna. If I exit and come back, will it end the meeting? No.
Will it end the meeting? No.
I'll be right back. Sorry for this.
I'll be right back. Sorry for this.
Interesting. Jess Workman.
Yes, Workman.
Okay. I don't know why there
Okay.
the
I don't know why there
feedback. You didn't have this last time.
You didn't have this last time.
Jess, I'm going to assign you as host.
Yes, I'm going to
exit
assign you
and
as
come back.
host. I'm going to exit and come back.
that's not good.
Hello, hello.
Hello.
Still a delay.
Hello?
Still a delay.
It's an echo.
Okay. Give me one more. Let me
Give
try
me
something
one
else.
more.
Okay?
Let me try something else. Okay.
Hello?
Hello.
Still there.
Still there.
All right, bear with
I
us.
can hear you.
All right, bear with us.
I'm going to exit out of Zoom entirely.
Exit out of Zoom.
Hello. Are we okay?
Yes.
Jessica Ree, I see you nodding from New York. Jess Workman, nice to see you all. All right, sorry for the delay. Now I need to do one more thing. This will only take a moment, if I can. Oh, we're live on YouTube. This will be hilarious. We're already on YouTube, apparently. Good. So hopefully we can clip that. Okay, I'm going to share my screen and we're going to get going. Jess, can you, since I made you the host, can you make me the host now if you go into there? Or to enable screen sharing? See if we can. I'm going to
Did that work?
Yeah, I see. Okay. All right. Thanks all for bearing with me through this. We're good, right? You can see my screen. All right. I'm Pete Rumford. For those of you that I don't know out there, this is Spencer Lee, and we're here at IPA Physio in Orange County. Spencer's going to be helping me after we go through some of the early part of this material. The intention of tonight's course that we're going through is presenting from the physical therapy realm, how we oftentimes see and manage headaches in our patient population. There's a time and a place for other interventions such as medication, Botox injections, things like that, but that's not my realm, so I'm not going to be speaking to that. We have people that we refer to and work with for things when they become that, when they get to that point. So you'll be hearing me present on the conservative management of headaches, and it's going to be very hands-on after we get through some of this early information. So here we go. All right. So headaches are very common. I don't know how many of you out there are headache sufferers. And I believe that this stat is even not as accurate as it could be. It says at least 15% of Americans suffer from moderate to severe headaches. I believe it's more than that, and it varies, and it's on, off, and recurrent with individuals from time to time. But many people suffer from headaches to the degree that it is completely disabling or very disabling to some degree. There's different types of headache. It can be confusing when you're trying to figure out exactly what's going on. Is this a tension type headache related to muscle tension? Is it a migraine, and what are the specifics of categorizing migraine? Is it a cervicogenic headache? And again, with the cervicogenic headache, that's going to be my focus this evening as I present to you some information from our experience and from what research has shown us that oftentimes the neck is a major part of headaches. Now, headaches are a neurovascular and a neuroinflammatory condition. Oftentimes there is a trigger that can trigger a depolarization of the cervical cortex and induce a headache. There's many different mechanisms and there's many different pathways. There's something called the trigeminocervical nucleus, which you can think of as a relay station in the brain. And what the trigeminocervical nucleus does is it takes in all of the information from the upper neck, from the jaw, and from the head, and it processes that information and then sends that information up to higher brain regions to determine what is actually occurring, what is going on. This could be any type of sensation like hot, cold, pressure, could be related to vibration sense or light touch. But the brain takes that information, and based on the way that it processes the information, it dictates where the information is coming from and assigns a category to that. Now, if you may have heard of referred pain, and referred pain is like saying that the pain is actually coming from somewhere else. Where the problem is not actually where the pain is, or vice versa. And what can happen in this relay station or this nucleus is we can have tight muscles in the upper part of the neck, or we can have tight muscles in the jaw because you've been clenching all night. And that information gets relayed to the brain. And by the time it goes up to the higher brain centers and back down, the brain can misperceive that although it's tight muscles in the neck or tight muscles in the jaw, it interprets and assigns that pain to a region of the head. And so the trigeminal cervical nucleus is involved in different types of headaches. It's been shown to be involved in migraine, tension type headaches, cluster headaches. And because the trigeminal cervical nucleus takes information from the jaw, the head, and the neck, we see that the neck is often at least a contributor in headache conditions. It may not always be the cause, but it's often contributing. So that's as sciencey as we're going to get. I hope that all made sense. You may resonate with what's on this slide. These are characteristics of cervicogenic headache. This is from research. This is from a paper that's trying to classify cervicogenic versus migraine versus tension type versus other things. And while this is, from what we see in the clinic, consider this to be fairly accurate, it's not all inclusive as far as how the symptoms present themselves. But what I'll draw your attention to mostly is that there's oftentimes neck pain before, during, or following the headache. It can be exacerbated by neck movements and abnormal postures. When I was working in New York, I saw a lot of people with headaches that would ride in from the outskirts of New York on the subway or on the train, and they're looking down, reading the whole way, 45, 60 minutes, and getting them to stop looking down and putting constant stress on the neck was a relatively easy fix for some of those individuals. So associated postures of the neck can be a trigger for the headache. You'll often see shoulder and arm pain as well, and limited neck range of motion. And that can be localized to specific segments of the neck, or it can be like a global loss of motion, like unable to turn the head to the side. Now I've spent the majority of the time already, and the rest of the session will essentially be trying to figure out what are those jaw, neck contributors and what you can do about it to help reduce headache and prevent headache. But headaches are so multifactorial. Poor quality of sleep, not just how you sleep and how your pillow supports your head, which we'll look at, but if you're only sleeping 4 hours, or if you have interrupted sleep because you have sleep apnea, or a 2-year-old like I do and a new baby coming soon. If you have poor quality of sleep, that can be a major trigger for headaches. Hormone levels, fluctuation in hormone levels can be a major reason for headaches. Oftentimes women that we treat that have significant headache symptoms, they are correlated with their menstrual cycle. And that may be related to fascial adhesions in the pelvic region, or it may be having to do simply with the fluctuations of hormone levels triggering the headache. But remember, there's a trigger, and then that trigger causes a neurogenic inflammation or depolarization, which is then the onset of the headache. Dehydration can be a significant trigger. Too much alcohol, too much caffeine, sugar. We've tried to learn our lesson, but it still happens. We'll be working with a patient and we find these mechanical triggers and we do our best to help alleviate those. But what it comes down to is that there's something in their diet, and it could be sugar, it could be wheat, it could be dairy, you name it. Lots of people have different allergies. There's those broad categories, but for some people, it could be a specific type of fruit or nut. So we always want to make sure that we're not fueling ourselves with things that can be contributing and being a trigger for our headache. A lack of cardiovascular exercise can be a cause of a headache, but also exercise in itself can be a trigger of headache if you're doing things incorrectly. And say you're doing a lot of arm exercises and you're constantly utilizing the wrong muscles to perform the activity. And then I mentioned the TMJ contributions. We work with a lot of people who continue to clench and grind, and clenching and grinding can be stress related, but it can also be a sign of an airway or a breathing problem. And the way that we keep our airway open while we're sleeping is to grit the teeth together to prevent the jaw from falling back into the airway, which is the foundation really of snoring and sleep apnea. So again, there's lots of issues at hand. When we're working with our clients here, we do our best to really suss out each category as best as we can. And then we dive into that mechanical realm, that neuromuscular realm. What can we do to enhance mobility, enhance strength, coach posture, and those sorts of things. I'll mention as we go, if you have questions and you'd like to, you can always write the questions in, and we'll see those pop up. That should pop up under participants, right? If there's, any kind of questions there. And then we'll also have plenty of time at the end to be able to check that out as well. So here we go. All right, so strategies to prevent and improve headaches. As I was mentioning in the last slide, identify lifestyle triggers and stop picking the scab. If you don't stop doing the things that are making you worse, you will not get better. So what are those things for you? Is it related to certain foods? Is it related to stimulants? Is it related to dehydration or poor sleep or stress? Is it how stress always goes to your shoulders? Is it driving? Is it your 2-hour commute and how you're holding onto the steering wheel and gripping the steering wheel? What is it for you that is a lifestyle trigger that is picking the scab? And then how do you change or modify that? You can't stop doing certain things, but you can oftentimes modify things in a way that at least stop picking the scab. Number 2, identify physical triggers. That's where we come in, and that's what we're going to talk about tonight. If we work on improving our posture, enhancing the mobility of our muscular system and taking pressure off of some of those muscles that get very tight, improving our neck mobility and the joint mobility of our neck, if we do those things, we can make a significant impact in the majority of our clients who have headaches. I'm just going to check this real quick. All right, very good. Thank you. So improve your sleep posture. This is where we're going to kind of go back and forth between sharing my screen and not sharing my screen. Actually, Spencer, can I have you go behind and I'll have you demonstrate while we should be able to keep it on the screen. If I know my screen's small as I talk, but what Spencer's going to demonstrate is a lot of people sleep on their side. Okay. And if you're sleeping on your side, it's important, go ahead and face us, that your pillow supports you entirely from the shoulder to the neck and the head. I will stop screen share for just a moment so you can see us all the way. All right. You can see us big now, right? Okay, perfect. All right. So I'm going to come here where Spencer is. So this is a decent pillow that's got, it's a down alternative pillow. It can cushion, it can go right up under his shoulder and support his head in essentially a neutral position. What we see with a lot of people, even if they have a good pillow, let's put this under your shoulder. It'll be under the shoulder, and because it's under the shoulder, it's not really supporting the neck. Hopefully you can kind of tell that I can get my hand under his neck. There's no support for the neck. It supports the head, it supports the shoulder, but the neck's not offloaded. All right, that closes all the joints on the right side of his neck and stretches the muscles on the left side of his neck. Imagine spending a day like this, and when you got out of that position, you might have a neck ache or a headache, right? I had one gentleman who slept like this, and he wondered why he had neck pain. And it was the most breathtaking session I've ever had with a patient. I showed him how to use a pillow under his neck, and his neck pain went away. You can't take for granted, so that's why I'm going through some of these details. Oftentimes what we see though is, say, a pillow like this. This is pure down and it's not filled as much. And if Spencer's lying here on this pillow, you might see that it's not supportive enough for his head and neck. All right. In that case, he'd have to double it up. Or what I'll usually have people do is take like a folded towel and put it on the underside of the pillow so that it provides the ability to adapt like down does, which is good, and cushion, but it also has a little more support underneath it. So just be sure that your neck is in a neutral position when you're sleeping, if you're sleeping on your side. Now, if you go onto your back, Spencer, oftentimes if people are lying on their back, that pillow comes under the shoulders again, and it creates a situation where the neck's relatively under supported. Not only that, we seek support and we seek the ability to get to a position where we're stable when we sleep. So oftentimes our head will kind of fall to the side. And then you maybe some of you, I know I've woken up with my neck off to the side, and you wake up and you got a kink in your neck in the morning. So if you have these pillows that are down or down alternative, again, it supports to the shoulder and the back of the neck, but you can also kind of cushion it up to the sides and give yourself that stability side to side. Now, if you sleep on your stomach, I'm going to encourage you to try to stop sleeping on your stomach. Just go ahead and sleep on your stomach for a minute. When you sleep on your stomach, your neck is in end range of motion the whole time. unless you've done some variation, which is what we would encourage. Let's go into like a half stomach sleeping, where you got a pillow under the leg. You might have a pillow, like a whole body pillow or something like this. And then his head can be sort of at the corner of this pillow so that it's more in line with his spine. So I know I'm going through things pretty quick here, but the importance of how we sleep and how we position ourselves is critical. Now, you may be a person out there who has a headache and you wake up with headaches. Okay, for you, this is very relevant. You may not wake up with headaches, but you develop headaches throughout the course of the day. This is still relevant. And if you have neck pain or shoulder pain or headaches, even jaw pain, make sure that you're supporting yourself well when you sleep. All right, overall posture. Posture matters. There's people out there that'll tell you that your posture doesn't matter, how you move matters, but how you are in static positions doesn't matter. I argue that we spend a lot of time in static positions. Those of us that work at a desk, even as we're working on patients, sometimes we may be in the same position for an extended period of time. What you'll see in this picture in the middle of the screen, and what you'll see on me here, is if I slouch from my base, in order to keep my eyes on the horizon, my neck is in relative extension. If I keep my neck the way it is and I sit up tall, you see how I'm kind of looking up. What does that do? It puts pressure on the muscles at the base of my neck. Whereas if I can just drop my chin down and be in a more neutral position, I take stress off those muscles. But if I'm slouched, I'm not going to be here, because then I'd just be looking down. So your posture is dependent upon your base. And if you're sitting, your base is your pelvis. You can't be sitting on your tailbone. You have to be sitting towards the front of your pelvis. If you're standing, you can't be standing with the weight back in your heels, leaning back like this. You need to be standing with the weight in the middle of your feet. I'm not going to get into too much more detail there. I've put a link to our blog on the bottom of this screen, just with one particular article, but there's multiple articles that I've written in there on standing and sitting posture and office ergonomics to encourage you in how you can align and position yourself in a way that's going to take stress off the neck, take stress off your back and your whole system. Get a quick sip of water here. Now, the other picture, where I'm just standing there looking forward, is to demonstrate the shoulders not being rounded forward. So what I just finished in the pictures, and you can feel this on yourself, is if you shrug your, I'll stand for this. If you shrug your shoulders up, rotate your palms and elbow creases forward, and then drop the shoulders down, what you've done is you've opened up the front of the shoulders through that external rotation. We're not forcing our shoulder blades back and creating tension that we need to hold. We're just trying to open the front so that we are not allowing our shoulders to fall forward. Because if our shoulders start to fall forward, we're putting strain on the upper trap, which again attaches right into the back of the neck and can be another one of those headache triggers. So you can also, like in sitting, just put your elbows at your side and open out to the side, and then from the elbow, without bringing your shoulder blades forward again, bring your arms back to where they were to cue yourself to not let those shoulders drop down. Even if you're like this, putting your thumbs against your shoulders with your arms as vertical as possible, this is a good self-check position to make sure that your shoulders are back and not tipping forward. All right. You've probably all seen this somewhere. I've seen it in multiple places, the text neck. And it is pretty, yes, I'm seeing the chat here. I will put the posture link in the chat at the end. Please remind me. Very good. All right. It's interesting to see that as that neck moves forward, the relative weight of the head. And I see this all the time. I'm guilty of it occasionally, but more and more rarely. But people are looking down at their devices all day. And as we're looking down, again, we're putting so much strain on the neck. And it's so much stress that over time, the muscles start to rebel a little bit. They start to send information to that trigeminal-cervical nucleus, which sends information to the brain, which may get relayed, mixed up references and perceive a headache because of the tension in the muscles of the back of the neck. So we're going to talk here about bringing those devices up to us, not looking down at the devices. So I'm going to share my screen again, or stop sharing my screen so that you see me. All right, here's this is one of our waiting room chairs. You can kind of see me here. And if if you tilt that down a little. So if we got a patient waiting to see us, all right, it's always like this, all right? Checking email, doing what they got to do. How many people have a headache from the election process? Raise your hand. A couple people, maybe. Been interesting, right? But people are sitting here looking down, slouched, and we might do this at home, watching TV, working on something on the couch. Some people with quarantine, they're working from home, they're working from their bed, not in the most ideal posture. At least have something like a pillow on your lap so that you can be in a position where the arms are supported and you're looking straight forward. All right, sometimes you need to have a pillow on each side where each arm is supported, but you can be looking forward and not have to be looking down. And then you get the added benefit too of the weight of the arm being supported. And when the weight of the arm is not supported, it's a weight pulling on the neck. All right. So make sure that you're supporting yourself and not looking down at your devices, but bringing your devices up to you. And it's annoying to, at least I think so, be here on my device. But if I've got something under my elbows, I can be here and it's not so tedious and it takes a lot of pressure off. Okay. Back to the PowerPoint. Don't get text neck. That's the moral of the story there. And we talked about some of the muscles that are most responsible, or how muscles can be responsible and be trigger points in areas that trigger the trigeminal-cervical nucleus and how that can spur a headache. What we're going to do now is palpate, which means to feel on ourselves some of the key muscles. And you may feel as I walk you through each muscle group that the muscle itself is sore. Okay, that's relevant. But if it's sore and it also refers pain to the location that you have your headache, that's like super relevant. And I want you to know that, keep that. And what you're going to do is you're going to sustain pressure on that point, and you can do a little bit of a gentle massage rub until that referral pain diminishes. And in doing so, you're going to enhance the mobility of the fascia and take away some of that referral pattern that's occurring. So we'll go through a few of these primary muscles. Now, the first two, these are related to the jaw. So I'd like everybody to do this on yourself. It'll be a lot more fun that way. If you take your fingers just above your ears and maybe slightly forward and you bite down, you should feel the muscle push into your fingers right there. This is called the temporalis muscle. On this diagram, I've put common referral patterns from this muscle. So if you have pain going up over your eye or pain that's kind of referring down, I have seen patients with tooth pain related to referral from this muscle in the past. So it is known to be a trigger there, but you can see that it also can refer towards the back of the head. If you work along the course of that muscle, which you see outlined on the slide, and feel if there's any points that are particularly sore, I've got one right here. And if it's particularly sore, but also refers pain in a way that you have a headache, X marks the spot. I want you to remember that. And you can keep some pressure on it as I talk through the others, or you can come back to it afterwards. Now the masseter muscle, that one's hard to miss here on the cheek. If you go just below the ear at the angle of the jaw and you bite down, okay, that muscle pushes into your fingers. So feel through that muscle belly. And for some of you are therapists out there. Some of you are clients of ours out there. Some of you I don't think I know. So you have various levels of feeling like, what should this feel like? But with practice, and this is what we want for all of our clients, is for you to become a detective, for you to become independent, for you to identify ways that you can manage these things on your own. So if you find an area within the muscle belly that's particularly sore, you can, again, kind of just sustain pressure. You can give a little bit of circular motion. And if it refers pain in a way that mimics your headache, I want you to stay there until the pain diminishes. All right. And you can, again, come back to it or keep working as we go down. Common neck myofascial trigger point locations. I'm going to start with the suboccipital muscles. So if you take your hands and go center line of the back of your head, so you drop into like a soft space. Okay, so your skull ends and you get to a soft space. Then if you go down a little further, you'll feel a little bony bump. That's the back of your second neck vertebra. Now, from that bump out to the bump that's behind your ears in both directions and up to the base of the skull, those are your what's called your suboccipital muscles. They're named that because your occipital bone is the bone at the back of the skull. These are probably the major headache trigger that I see when the neck is involved. So easier to feel if you're lying down and your head would be a little bit turned to one side, but you can still get your finger in along the back of that occipital bone and the base of the skull and push with your finger on a few locations. Many times these muscles, when you find a spot that's really tight and tender, will refer to the behind the eye or up and over the eye or over the side of the head. Most of the time, it's on the side that you're on. I've seen it across, but usually if I'm on my left side, it's going to be behind my left eye that I feel the discomfort. Okay, so those are primary muscles that are playing a big role in headache problems. Now, the splenius cervicis and splenius capitis muscles are more center line muscles going down the back of the neck. All right. Most of the time, once we get an inch or two from the back of the head, we're starting to see, or below the base of the skull, we're seeing a little bit less likely referral up into the head. But nonetheless, you can work down the back of the neck and feel where is the muscle stiff, where is it sore, and use your fingers to get into some of those places. Again, if it's sore, that's important. If it's sore and refers pain, you sustain your pressure at a point that's tender but tolerable. You can circle with your fingers and keep circling until that referral pain goes away, which helps to reduce the headache pain. Now, this muscle here in the front of my neck, it's called the sternocleidomastoid, okay? And if I side bend and rotate, if I side bend to the right and rotate to the left, you can kind of see it pop out. It goes from the collarbone to the bump right behind the ear, right below the ear. All right. And all along that muscle, if you kind of pinch it with your thumb and your index finger, I see a lot of people with trigger points in this sternocleidomastoid. This is one of those muscles that takes over for the neck being too weak. And we're going to go through a few neck exercises here soon. But if you can't stabilize your neck well with some of the deep core muscles, you start overworking, overusing this muscle, even just like lifting your head when you're lying on your back. All right. So again, for this one, I'll usually use a thumb and an index finger to pinch, and I'll find an area that's sore. I've got a little bit of referral coming up towards my eye, and I just sort of roll between my fingers and sustain that pressure. You can tilt the head away and get a good stretch through that muscle as well. The upper trapezius is the last one that we're going to talk through. If you go down the side of the neck to the top of the shoulder, that's the upper trapezius. Now there's some other muscles in there too, depending on where you're pushing. But if you're working through the top of the shoulder, this is where I'm going to take this implement. Some of you may have something like a theracane, and you can get the theracane on one of these spots, one of these tender points on top of the shoulder. just tender but tolerable. Whenever you're doing these sorts of things, remember, we don't want to pick the scab. So if we help it and it feels better, we're doing good. If you feel like it makes it worse, maybe it's too much force, that's where we need to dig a little deeper and use less generalities. But if I sustain a little pressure on my upper trapezius, I can rotate my head, maintaining that sustained pressure. I can use the Theracane and I can kind of massage back and forth, and that can help a lot as well. You may have seen these. These are okay in general. For the head and neck, it's, I'm not going to use these on my suboccipitals, please don't, or my temporalis or my masseter. I might use this like on my upper trapezius or have somebody do it for me. But just be careful if you're using these Theragun or Hypervolts that you're not hitting bony areas, because I see that. So I just want to mention that. So moral of the story is many muscles can refer pain to the head and mimic headache symptoms. And if you get those muscles loose, then that's going to make a big difference and take the pressure off of the fascial system. Now, a great general neck stretch, and I'd like you to try this on yourselves as well, is if you take your hand and you grasp the back of the neck. Sometimes you'll feel like you're only really grasping the skin, but there's a structure called the nuchal ligament, which connects all of the vertebra in the neck. And the goal is, if you can grab the skin and give a little bit of a backwards pull and look down without letting the skin pull forward, you can get a really good fascial stretch to open up the tissues in the back of the neck. Again, it's a general stretch, but oftentimes it's very effective. Now, we're only looking down here for about 5 to 10 seconds while we're holding the stretch, and then we're looking back up. We're not staying down there and looking at our devices. What you'll see in that other picture, my friend Nick here is working on the ability of his lower part of his neck to assist the mobility of the upper part of the neck. So he's taking his right hand and, do you mind grabbing the spine model? Sure. He's grabbing the bony processes. If you reach behind your neck to the base of your neck and you feel the little bumps back there, when you turn your head to the left, those bumps should move to the right. Okay? So this is a spine here, and you can see the bumps in the back. When you rotate the front in one direction, the back moves in the opposite direction, like the rudder of a ship. Okay? So if I'm turning my head to the left, I can assist that rotation lower down in the neck, again, to take pressure off of the upper neck by taking my fingers on the left side of those bumps. So say like the left side of the rudder. And as I turn my head, I'm using my fingers to guide those bones to the right. So enhancing mobility of the upper thoracic spine to offload the neck. Many people, when they're driving or they're moving in general, and they're looking left and looking right, they're just using their neck. And they're never getting that rotation to move more through their system, again, to offload the neck. So this is a good way to not only self-mobilize that upper part of your mid-back to assist the neck, but to remind yourself that, like if you're in your car and you have to look behind you and you have to look to the right, shift onto your left sit bone. You have to look to the left, shift onto your right sit bone. Use the rest of your body as much as you can to offload the neck, particularly if you're suffering from neck pain and headaches. All right, we're going to go through a few exercises now. And what I'll have Spencer do, let me see. Spencer's going to be on. I'm going to coach him through a few things. And I'd like you to try these on your own while I'm going through them. The first is going to be rotation propped up on your elbows. So forgive me, I'm going to pop back and forth from sharing to not sharing. Now I'll be right here. This should be fine. All right, so you should be propped up on your elbows as you see Spencer is. Again, the point of this is rotation through the shoulders and through the whole system, not just the neck. So what he's going to do is as he's propped up on his elbows, he's going to turn his head and look down the right side of his body. But as he does, his right shoulder drops back and his left shoulder comes forward. And then as he comes back to midline, he gets back to that neutral position. And when he turns his head to his left shoulder drops back and his right shoulder comes forward. So you should feel this moving through your whole shoulder girdles, your thoracic spine, even down into your lumbar spine. Go ahead and go a couple more times each way. Just like the last thing I mentioned with the upper mid-back mobility, as you do this, we're trying to tell the neck we've got support, we've got help through the whole body. It's not just on the neck to rotate and move, but we can do it from the rest of our body as well. This is a great shoulder, neck, mid-back exercise. Now the next one, and you have these in your notes, so I'm just gonna have Spencer go through this. You'll see lying on the back with the arms out to the side, head supported by a pillow. There you go. You're gonna let what you see in the picture is my head's neutral, but what I want you to do is, without lifting your head, just let your head rotate in one direction as far as comfortable, and then rotate the knees in the opposite direction. And you can hold that for about 2 to 3 seconds. Knees come back to midline, head come back to midline, and then you go in the opposite direction. What we're trying to get here is whole spinal mobility. So we're getting rotation and counter rotation through the whole spine. This would be relevant and very helpful as well if you're just dealing with your neck's limited in one direction rotationally. Work more towards that direction of neck rotation without getting into pain, and let the body rotating in the opposite direction enhance your relative rotation in the direction that you're limited. So this is a good trunk rotation activity that you can do. Now, if he comes on to hands and knees, most of you know the cat-cow. I'm always surprised at how hard this can be for some people based on coordination and just not having done it. The main things that I see people do wrong are they're unable to keep their elbows locked out as they go through the exercise. They start bending their elbows, okay? And what does that do? It puts more strain on the neck and shoulders. So the elbows have to stay locked, preferably the elbow creases are coiled forward a little bit, all right? Now, as he rounds his back, the head finishes the round and the tailbone tucks down. So he's got the tailbone tucking down and the head dropping down. This should all be in a comfortable range. And then as he reverses that position, tailbone goes up, head goes up. Now, what you'll notice in this exercise is if he just stays in this same position with his hands under his shoulders, his knees under his hips, he's always going to move his spine in the same way, and that's better than nothing. But if he shifts his weight, say, backwards a little bit and stays there while he arches and sags through his spine. So it's a general exercise, but we like to encourage people to make it more varied. He can do the same sort of thing where he shifted forward now, and you'll see how the extension now will get a little bit more into his low back versus higher, and it changes where in your spine you're having to move. Now, let's talk about breathing. So you can look at the screen for a moment, and then I'll have you lie down and just practice this and feel a few things on yourselves. The reason I have this diaphragm here, and hopefully you can see it against my shirt. As you breathe, your diaphragm, which is a dome-shaped muscle, should push down. Okay? As it pushes down, the stomach expands because you have this domed muscle that sits in your ribs, just like I have this plunger at the base of my ribs right now, pushing my abdominal contents down. Many people don't breathe effectively using their diaphragm. And instead of allowing the diaphragm to descend, which decreases pressure, which causes air to come in to the thoracic cavity, what people do instead is they pull air in through elevating the ribs, elevating the chest, and using a lot of the neck muscles to try to pull air in as opposed to breathing effectively through the diaphragm. So I'd like you to lie on your back. Spencer, you can go ahead and lie on your back again. And get a sense on yourself if you, as you inhale in a relatively light to moderate breathing state, if you initiate with the abdomen pushing forward, or do you initiate breathing more into your chest cavity? Now, put your fingers along the front of the neck, next to your, just a little wider than your thyroid cartilage. I had a patient today, she's a woman, she's like, do I have an Adam's apple? So I was explaining this. But if you put your fingers on the front of your neck, and what I'd like you to do is a quick sniff. Okay, and when you do a quick sniff, you'll feel the muscles of the front of the neck fire. Okay, that's normal when you do a quick sniff, but it should not happen when you're in a resting breathing state. All too often, we see many patients, those with headaches, those with neck pain, those with shoulder pain, those with poor core activation, breathing using those muscles that would activate when you sniff, just when they're doing a regular breathing state. So to train yourself to breathe diaphragmatically, it can be challenging, but you put one hand on the stomach, one hand on the chest. For some people, this is like, let's get on with this already. But for some people, this can be really challenging. And to exaggerate the diaphragmatic breath, try to expand the stomach without expanding the chest. Now, in normal breathing, the chest will expand at the end, but I want you to emphasize that stomach part. And what I'll usually have people do is inhale for 3 seconds, and then hold that breath for 3 seconds, and then exhale for 3 seconds, and then hold for 3 seconds. So it's 5 breath cycles per minute, which also decreases your breathing rate. Most people breathe about 12 to 18 times per minute, and that's really over breathing. We need to moderate many things in our lives. Many of us breathe too much, and it throws off our CO2 and our oxygen balance. So you can practice this breathing pattern. If you feel those neck muscles firing, or you feel your rib cage and your chest wanting to dictate movement when you breathe, this is something that you really need to work on. Now let's get into some neck strengthening. So as we get into these, it'll be a little bit more challenging for some of you, but yeah, I'll have you stay on your back. And I'm going to go back to this real quick. Are there any questions that have come up in the chat box? Let me just see before we keep going. I'll answer some of these at the end related to, yeah, we'll have some of these. Okay, these are great questions, but I'm going to come to them at the end. All right, so you can still see us here. The exercise that I'm having Spencer do right now is what we call a neck isometric. And what he's going to do is he's going to simultaneously resist the muscles of the back of the neck and the front of the neck. So it starts with a chin tuck. And what he's tucked his chin as if there was a bar through his ears and he was just pivoting on that bar. All right. Once he's in that chin tuck and he's got a little bit of length, through the back of his neck, he has one hand under his head, right at the base of the head, and then he has a thumb under his chin. Tongue is on the roof of his mouth because that helps to stabilize the anterior structures of the neck. And what he's going to try to do is using his left hand, he's trying to untuck himself, but he's resisting with his neck muscles. And using his right hand, he's trying to lift his head forward, but he's resisting with the back neck muscles. So the result of it is there's no motion, but with about 30% force, he's trying with his arms to move his neck like this. All right, show them what it would look like if you won with your hands, right? But he's keeping his neck back and he's keeping his chin tucked. So I'll have people hold this generally, 10-second hold, 30% force, and up to 3 sets of 10 daily. The reason I do that is there was a pretty good research article that came out about 2 years ago that showed that people that adhered to a regimen of 3 sets of 10 repetitions, 10-second holds daily, saw an increased curvature of their cervical spine by 4 to 7 degrees. So we know that many people who have neck pain, headaches, whiplash disorder, that sort of thing, they tend to have a flat or a straightened cervical spine. It loses its lordosis, its ability to shock absorb. So by firing the correct muscles in the correct manner and starting with just a hold like this, it was cool to see on X-ray imaging that you can actually enhance the curvature of the cervical spine. Now, moving on from there, Spencer's going to go onto his stomach. You can do this. Why don't you do it not hanging off the edge of the table? Start with kind of your forehead on the table, and then you're just going to draw your head back without extending. So you essentially want to be so that your head, you could slide a couple pieces of paper under your head. And what he's having to do here is he's keeping his chin tucked, but he's using the muscles of the back of his neck to hold his head and not allow it to hit the surface. Now I want his palms facing downward and his hands lifted so that his shoulder blades are engaged together. Minimal activation through the lower back. In order to cue less activation through the lower back to try to do the lifting, go ahead and push up on hands and knees for a second. Put a pillow under your stomach so that you're not as extended and you have a bit more support there from the start. So the palms are facing down, the shoulders are back in together, the head's lifted a little higher now because he's got the pillow under him, but try your best to not overly grip with your paraspinal muscles. So you can hold this position, and the overall goal, as I have on the slide, would be about 2 minutes, but start with what you can do. There shouldn't be pain when you're doing these exercises. There should be effort, but not pain. Now, you can also do like shoulder exercises to strengthen the shoulder blades. He could lift his arms up a little higher and go back down. He could come out to the side position and lift up and go back down. Okay, he could alternate doing something like go ahead and bring this hand behind your back and this one behind your head. Okay, and then switch positions. Where he's working on shoulder mobility and flexibility while he's holding neck stability and shoulder blade stability. So there's lots that you can build off of and do in this position for the shoulders as well, but it starts with having that ability to maintain that stable position. Okay, now go ahead and roll over onto your back again. We call this a hover hold. This is a progression from the isometric exercise where you are resisting the back of your neck and the front of your neck at the same time. So what Spencer's going to demonstrate here, and I want the legs the way that he has them, because if his legs are straight, there's just more tension through his spine altogether. He's going to support his head with that one hand underneath, and you can try this as well. He's going to tuck his chin. He can keep that hand there under the chin as feedback, but then the goal is he'll slide his hand out without letting the head lift at all. And you should be able to keep the chin tucked and the head lifted without deviating from that position. Tongue should be on the roof of the mouth, mouth closed. If the chin starts to untuck or the head starts lifting forward, as he's demonstrating, stop. If you have pain, stop. You should feel some co-contraction, like even the muscles of the back of the neck are stabilizing. But sometimes people, particularly with headaches and neck pain, will start to feel this at the base of the skull, like it's doing all the work. If that's the case, go back to that isometric and stay there. Gain your strength that way before you progress to this. The goal for this is a minute. You should be able to hold this for a minute, or at least 40 seconds based on some of the latest research that I've read in individuals who don't have neck pain. But I like to shoot for a little bit better than that. All right, I'm going to come back to screen sharing. All right. So those are, again, I'm speaking in generalities here. We've looked at how to work through your own fascial system a little bit and identify some of those triggers, how your posture can contribute to some of the symptoms that you may be experiencing. It might be that you're looking down for so long and over a period of time, pain starts to arise. You might have a lot of tension in the shoulder blades, and over time, that tension starts to trigger a headache. And once that headache's triggered, it's really hard to diminish. Those of you with headaches know. It kind of goes through the cycle at that point. So I want you to think about how you manage your posture, how you manage some of those own trigger points that you find on yourself. And then remember, how do you offload the neck through better mobility, not only of the fascia, but of the upper mid back behind? And how do you increase your strength and your stability so that the muscles of the head and neck are stronger? I've had patients in the past that are lying on their back, and just lifting the head off the pillow is painful, almost provokes a headache. And you've got to start somewhere, because that weakness is not going to get you anywhere. But you can't start with like that hover hold position. You may even start with just small chin tucks. and start activating the front neck muscles. And it may not even feel like much, but you start to activate the muscles, get some blood flow, go to the isometric, and then go to the holds and progress things from there. But again, these are generalities. These are things that help many people. These are things that I want to share with you all and clients of mine that generally help people. But everyone's different, and your case may be different. And beyond what we've gone through with the generalities, there's oftentimes some very specific dysfunctions that we find. One of the questions that I saw in the chat box was related to, let me see where I pull that up again. I'm just going to read this question because it led to, what about arthritis at the top of the spine neck? What can we do there other than medication? So what I'm going to talk to that I'll answer that question, but speak in broad terms as well. Particularly C2 and C1, which are the first two vertebrae of the neck that sit right under the head. Mobility of those joints is often dysfunctional in people with headaches. And what we find is that it may be sort of an offset alignment based on fascial pulls, that one side feels like it's getting really pulled forward or one vertebra feels like it's getting pulled forward while the other is getting pulled back, or someone may be in a habitual side bended posture like this, and the ability of that vertebra to glide in the opposite direction is diminished. Habitual patterns, injuries, whiplash, things like that, they can lead to arthritis. But it doesn't have to be arthritis. That's my point. It could just be that the joints are very stiff. The fascia is really stiff. So we get in with our hands and get things moving more specifically, whether it's the joint mobility or the fascial mobility or nerve tension and neurodynamics related to how the whole nervous system is moving. So I hope that answered the question. But I also want to say that if you feel like some of these generalities aren't getting you where you need to go, we need to look more specifically, or we can work with you and enhance the process and make it more expedient and efficient. I put a slide in here because I want to just briefly touch on this. And then again, there's a blog, and I can put these blogs in the chat box before we leave. Central sensitization refers to the fact that in those with chronic pain, and that can be broadly defined. And one way I'll define it is pain that lasts longer than it should, if the only issue was, say, tissue healing. When pain persists, the body gets better at perceiving the pain. And that in and of itself can become a disease process, for lack of a better term. Migraine and central sensitization are often linked. Headaches and central sensitization are often linked. What that means is your brain is receiving too much information from the periphery. That information may not be bad information. It may not be hurtful information. It may just be the amount of information that the brain is receiving is overloading your nervous system. And so one of our goals as therapists, and if we're working one-on-one with a patient, or if you're going through exercises and all these mobilities on your own, is that if you get stronger and you get better mobility, you're going to have less inefficient information being sent to the brain. You're going to decrease the amount of information that's being sent to the brain, and hopefully take that threshold down so that you're able to not get triggered at this level, and you would have to get triggered at this level, or the sky's the limit. Again, it's a broad topic, but if it piques your interest, there's the blog there. I know you can't click on it, so I'll put these in the chat box before we go. Here's our information. You do have this. You can always contact us by this. I'm going to go to some of the questions in the chat box now, and I'm going to stop sharing my screen to do so. Thanks for all of your attention. Let's see here. I will, I may ask some of you a question based on your question, and if I do, I'll just unmute you. I think I still have everyone muted. Here it is. Okay. Hi, someone said, a lot of good comments. I encourage you guys to look at these comments too. Some of these are just comments from some of our colleagues and other therapists as well. So if you read through some of these, yeah, I'll put the posture link in there. The arthritis at the top of the spine. I hope I answered that question. That's from Leslie Young to me privately. Sorry, maybe you didn't want me to share that. Apologize for that. But if I didn't answer your question, please let me know. Do I ever use a pillow under at least one elbow during long car rides? Yes, and I encourage that to other people, especially if your car doesn't specifically support your arms in the way that it needs to. Bring a pillow so that it supports the weight of the arm. That could be for headaches, that could be for neck pain, that could be for nerve tension, that could be for a lot of things. There's a question about Cabot's impact testing and tonic muscles read. We do use impact testing. This is more a therapist related question. I don't do it specifically Cabot's way, but we do utilize that. And Roberta, you and I can talk about that in more detail. Very good. Could text neck or weak neck muscles trigger a headache whenever you lie on your back? Yes, it could. It depends how you're supported when you're on your back. And that's a case where I'd want to see as well what the neck feels like when you're on your back. If you're lying on your back and you're supported well enough, the muscles should be able to relax. But that being said, if it's the sort of thing where you get to a lot of people don't notice certain symptoms till the end of the day. I hear this with a lot of things. It can be a headache. It can be ringing in the ear, which can also come from the neck, but you don't really notice it till the end of the day when you lie down. So it can be a delayed onset, a delayed reaction, but it could also be how you're positioned when you're lying on your back. I want to unmute everybody and some of the people that are answering these questions. I'll unmute you if you want to unmute as we go through these. A bit of an aside, I'm excited to read this one. But since you touched upon cat-cow and people having difficulty getting it, do you have tricks to help people find mobility in their pelvis as opposed to driving from the cervical spine? Katerina Fishman, I'm going to try to unmute you. Katerina, will you show yourself?
Hey.
Hi, Katerina.
Sorry, I have my computer set up in a weird way.
No worries. Tell me your question again. I like to hear it versus the reading of
Yeah,
it.
so I guess I find this a bunch when I'm trying to teach, not just for the sake of the headaches, but just teaching mobility for the pelvis, whether it's in quadruped or even like seated on a physio ball.
Yeah.
And for the people who actually really need it are the ones that are really tough to teach. So they're driving from the cervical spine or they're trying to compensate up here and they're really not getting that motion. Yeah.
My thought process there goes to supine pelvic tilt first, combining supine pelvic tilt with diaphragmatic breathing and feeling how like the anterior tilt of the pelvis is going to function all the way up to the cervical spine. Otherwise, stabilizing the upper body somehow, whether it's resting over like an exercise ball with, so they can't really go up and down with their head and just working on the tucking of the pelvis. But that's something that we would look at there. Sometimes you see the opposite where they only want to drive from the pelvis. And the biggest issue I see there generally is thoracic stiffness and the difficulty moving through the thoracic spine. And I think whether it's inability to move from the pelvis or inability to move, or sorry, if they're driving from the pelvis or over driving from the neck, in either case, usually they're not moving enough through that thoracic spine. So it's isolating ways where they can get more thoracic mobility and then integrate that.
All right. Thank you.
It's a good question. Are there any other questions? Okay, those of you that want to hang on, I'll get my copy and paste on those blogs. Actually, I'm gonna just put the blog itself, and then you can look at articles in the blog that you find relevant. So I'll just have the general page to our blog up there. And then there's multiple articles on posture, and central sensitization. I wrote a blog on headache, which has a lot of this information, but not all of it. This is a lot more than what's in there. And an article on TMJ dysfunction and things you can do about TMJ dysfunction. So there it is in the, sorry, I just sent that to one person. I want to send that to everyone. There you go. So now you all have the blog there, and go ahead and copy that. Any last questions? Thank you for being with us. Good to see friends from New York and California and all over. Really appreciate you taking the time and joining us. I hope you found the information valuable and that you can apply it immediately. And we're always here. If you have any questions, I'll put this up here one more time with our phone, our email, and our website. And thanks again. You guys have a nice evening. We'll see you soon.
Thank you.
You're welcome.